All right. Good afternoon, everyone. Nikki Anderson. I'm the Stroke System Nurse Specialist here at MDH. Thank you for joining us today for our first webinar back after summer break. We hope you've had a great summer and an opportunity to enjoy life. And we are delighted to spend the next 30 minutes with you. And I'll look forward to Dr. Asathambi's presentation on delivering quality care during the COVID-19 pandemic. As usual, we just have a few quick MDH reminders and updates to share before we hand things over. Now, your lines have been muted upon entry, and we do encourage you to type your questions directly into the chat during the presentation, and as time allows, we'll get to questions at the end. And on to our few quick updates from here at MDH. First of all, I just want to say welcome back to Michelle. She had a healthy baby boy in April and has recently returned from parental leave. Many of you have heard from her already as she quickly jumped right back into scheduling site visits. And for those of you still awaiting your visits, she will be in contact in the coming weeks. And another update as far as contact updates, you guys have done a great job of updating us here with contacts for your program. Please keep it up and let us know anytime there are staffing changes within your stroke programs. Now, Al shared the fabulous news in his most recent monthly letter that we were indeed refunded by the CDC, which is super exciting. There are 13 states that were funded, including Minnesota. Some of our work and strategies may shift towards the bookends of the continuum, meaning and transitions, but the rest of the stroke continuum of care remains equally important. And we are very excited for this next chapter and look forward to sharing more information in the weeks to come. Thank you all for your support during this time and for everything you've done in building and maintaining the Minnesota stroke system. And lastly, we wanted to remind you all that the Minnesota Stroke Association's Minnesota Stroke Conference will be held in person on November 4th this year. They are still accepting proposals, so please utilize the link we sent before regarding call for proposals. I'll make sure to send that in the follow-up email as well. Talk to your providers and neurologists, rehab specialists, those you work with within your stroke program to see if anybody would be interested in presenting. And I'm looking forward to seeing many of you there in person. Today, our webinar is on COVID-19 and stroke. And we did have a webinar of the same topic nearly a year ago at a time where we were all still learning so much about the virus and how it affects the populations we work so closely with. We are still learning and we'll be learning for years to come. We will be offering contact hours for today's program. You will receive your certificate upon completion of the survey, which will be dropped into the chat box at the end of the learning, as well as shared in the follow-up email at a later date. You can most certainly respect this, you can most certainly expect the follow-up email that includes the links provided here today and this copy of the slide deck sometime in the middle of next week. With that, I am delighted to introduce Dr. Ganesh Asaithambi. Dr. Asaithambi is a board-certified vascular neurologist who serves as the medical director of the Comprehensive Stroke Program and chair of the Department of Neurosciences at United Hospital. Ganesh, the floor is yours.
Thank you, Nikki. Good afternoon, everyone. I wanted to thank MDH for inviting me back. I had the privilege of speaking on the topic of COVID-19 and stroke last August, and I'm happy to return to kind of share more information as we've collaborated over the past year as a state, as a community, to help serve our patients. So first, I have nothing to disclose. Next slide. And the objectives for this discussion this afternoon. First, we'll review recommended metrics to enhance quality of stroke care for hospitalized patients. We'll compare the provisions of high quality care before and during the COVID-19 pandemic. And finally, we'll discuss strategies to continue delivering quality of care during the pandemic. Next slide, please. So back in March 13th of 2020, the United States declared officially a national emergency in response to the COVID-19 pandemic. At the same time, CMS announced that patient hospitalization data from the first 6 months of 2020 would not be used in any hospital-based performance or payment programs. citing the need to focus on preparing for a potential surge of patients as we all experienced. Other quality improvement programs funded by or supported by JCAHO and others followed suit based on these CMS recommendations. Since the start of the pandemic, what we've learned is that what we've learned from several studies is that there's been a significant reduction in the emergency department visits and hospitalizations related to stroke. This was largely related to stay-at-home orders, social distancing, and certainly the fear of contracting COVID-19 in healthcare settings. These reports are of course concerning given the established benefits of time-sensitive acute stroke treatments on long-term outcomes and the association of lower 30-day mortality rates among patients treated within an integrated stroke care system. Next slide. So the question remains, as we have learned from evidence-based reports, newspaper articles, news, everything, we know that the number of patients that sought medical care, irrespective of the condition, so even beyond stroke, cardiovascular disease, or anything else, we know that there was a reduction in hospitalizations related to non-COVID related illnesses. But what we don't know specifically is how did the pandemic affect delivery of quality care among stroke patients? We have an entire system in place through MDH, through the Coverdale program, through Get With the Guidelines, and a variety of other governing entities that allow us to be designated stroke centers or acute stroke ready hospitals that give us an algorithm, a recipe list in which we follow in order to ensure that we are providing top-notch care to those that are hospitalized. But what did the stress of the pandemic itself cause or result in the type of quality of care that we're delivering to the patients that we do see in the hospital? Next slide. So using data from the Coverdale Stroke Program, we examined 406 hospitals. So within this time period that you see there, 406 hospitals from 9 states. So March 10th to June 15th of 2019 that we defined as pre-COVID, and March 8th to June 13th in 2020 as the COVID era, which correspond to weeks 11 to 24 in both timeframes. We studied hospitalization data based on stroke patients, and those patients included those with hemorrhagic stroke, so including intracerebral hemorrhage and subarachnoid hemorrhage, ischemic stroke, and TIAs. Next slide. So with studying these patients, we estimated the percent reduction in hospitalizations overall. We then examined rates of adherence to performance measures, which we'll go through. And then we finally examined the percent of patients who received defect-free care, which I'll define in a moment. Next slide. So what are these performance-based measures? So the CDC, in collaboration with the American Heart Association and the Joint Commission, developed 10 evidence-based performance measures, and patients who receive stroke care that meet all performance measures for which they are eligible is defined as defect-free care. So you'll see in parentheses next to each performance measure which diagnoses those would be associated with. So of course, like for example, the first one, IV alteplase given when indicated. So that was only for ischemic stroke patients. Venous thromboembolism prophylaxis for ischemic and hemorrhagic stroke, antithrombotic therapy within 2 hospital days, dysphagia screening, discharge on statin medications, discharge on antithrombotics, anticoagulation for AFib, providing stroke education, smoking cessation counseling, and assessment for rehab. And in parentheses, you can see the associated diagnostic diagnoses for which that performance measure was assessed for. And then again, defect-free means that they meet all performance measures for that diagnosis. So defect-free care for hemorrhagic stroke would be different than for ischemic stroke or TIA. Next slide. So looking at our study period, we identified a little over 64,000 stroke hospitalizations. What we learned was that the overall reduction of hospitalizations from the pre-COVID era to the COVID era dropped by 20%. The biggest drop were among TIA patients, followed by ischemic stroke, and then finally by hemorrhagic stroke. The most significant reductions were found in older patients as well as women. Next slide. We did learn that there were more hospitalizations among younger patients, as defined as those aged between 18 and 64. And overall, there was a decrease in the number of ambulance services used. The onset to emergency department presentation increased from 4.5 hours from time of onset to almost 5 hours, a significant increase in delay in seeking care. And certainly those patients who were determined to be more severe, have more stroke severity or higher NIH stroke scale scores were more likely to present to the emergency department than those who had milder stroke symptoms or resolved stroke symptoms, which kind of alludes to the fact of why TIA patients were less likely to seek care. Next slide. So what we noticed, especially among ischemic stroke patients, that overall there was no real difference among those receiving acute reperfusion treatment. So that's both IV alteplase as well as intraarterial treatment with thrombectomy. However, if we looked at only the rate of IV alteplase utilization, there was a significant drop by about 5%, and the number of patients that received thrombectomy increased to almost 6%. All of these are significant numbers. The treatment times did not change dramatically. So onset to needle time, so those who were deemed eligible for IV alteplase, did not change overall between pre-COVID and COVID. And what was nice that we learned was that the door to needle times did not change dramatically either. Neither did the percentage of patients who were treated within 60 minutes or those who presented within 45 minutes. So no dramatic change in hospital-based efficiency metrics. Next slide. So these are the performance measures that I wanted to focus on. I was hoping I'd have control, but that's no big deal because I wanted to do some highlighting. But what I want to draw attention to is each performance measure the adherence to the performance measure did not change dramatically between pre-COVID and COVID. But what I want to highlight that we'll talk about in a moment are the opportunities that remain from pre-COVID to the COVID pandemic to now, which include first and foremost dysphagia screening. So we noticed that among the hemorrhagic and the ischemic stroke patients, dysphagia screening appears to be in the mid to upper 80%. Stroke education for hemorrhagic stroke has an opportunity to improve. Certainly among IV alteplase, of course, that is open to interpretation based on inclusion-exclusion criteria, but 94%, 93% is not bad, but there's a slight opportunity to improve there as well. So overall, there was no major difference between pre-COVID and COVID. Next slide. And defect-free care, and reminder what defect-free care is when a specific diagnosis met all performance measures. You'll see that there is no significant difference, but what you will also notice is that we are still overall in the 80% for all stroke hospitalizations, which is making sure that, and if you can go back up to the previous slide, making sure that each diagnosis, each performance measure was checked off for each patient. So while each individual each individual performance measure was adhered to, not every patient got 100% of each performance measure. Next slide. You can go to the next slide again. All right, so overall, we found a reduction in hospitalizations by about a fifth. Patients with milder symptoms or resolution of symptoms were less likely to receive hospital-based care. Rates of oldest of old patients, women, as well as non-Hispanic white patients declined the most. And while the overall reperfusion rates did not change for ischemic stroke patients, the rate of IV alteplase utilization dropped and the rate of thrombectomy increased. Next slide. Of course, we still have opportunities to improve that I just alluded to. The rate of defect-free did not change, but again, we're in the 80% for hemorrhagic ischemic strokes as well as TIA. the best opportunity is for stroke education, dysphagia screening, and IV alteplase utilization among those who are eligible. Stroke education is probably one of the more important performance measures because what we know about providing stroke education at the time of discharge, not only is it critical, it provides the ideal transition from hospital to the next phase of care and has been shown to actually reduce the risk of recurrent stroke and actually decrease health costs for patients. Um, To add on the IV alteplase utilization, of course, that's most likely related to the delay in seeking care. If you recall in a few slides previously, the onset to presentation extended from 4.5 hours to 4.9 hours for all stroke patients. Using IV alteplase as a consequence probably reduced because of the longer onset to door time. However, expectantly with intra-arterial treatment or thrombectomy, given the wide time window, it's no surprise that many patients receive that with increasing utilization over time with evidence-based support through guidelines up to 24 hours. I want everyone to keep in mind that it's not necessarily related to COVID-19 itself. I know we have read in the news and with journal articles that many younger patients with COVID can have large vessel occlusions. While that may play a role, I think that overall, more patients that are more severe in stroke severity presenting to the ED lends itself to the increased rate in thrombectomy. Next slide, please. So a lot of this is actually, or most of this rather, is going to be published on Friday through Preventing Chronic Disease, a journal published by the CDC. And so this is actually something that I thought I'd share mainly because one, we didn't really know how well we were delivering care to our stroke patients that were coming to the hospital. We've always worried about the drop in rates, but with the resources being spread so thin and making sure that all patients were getting the care that they deserved, it was important to share that data. And then second, of course, I published it, so my name's on it. So, or I'm an author, so I wanted to make sure I gave myself a shout out. That's a joke. I know everyone's muted, so I'm laughing to myself. Next slide. So basically, stroke hospitalizations decreased, but the quality of care delivered did not. Opportunities for improvement that existed prior to the pandemic still remain in order to increase the rates of defect-free care. The decreased rate in hospitalizations, it indicates an importance of strengthening public health efforts that promote the awareness of stroke signs and symptoms and the urgency for seeking treatment for stroke, even for those milder stroke syndromes. And then finally, keep up the good work. I think, over the past year and a half, we've been, again, stretched thin, stressed out, and making sure that we're trying to do everything. We don't take that minute to appreciate what we do, what each other does for the rest of the team. And, you guys are all stroke champions. And you guys have been doing an excellent job. I'm proud to be providing or being a part of a team within the state who is so engaged in stroke care. And that's irrespective of what system you are or what hospital you're a part of. To be able to deliver this high quality of care to our communities is something to applaud. And I think, everyone needs to know that it is truly appreciated. So thank you from me personally, but I'm sure many others that I work with would also provide that gratitude as well. And next slide. I think that's it. So thanks so much for your time. I know that was a short discussion, but I wanted to make sure there's enough time to have questions that I could try to answer for everyone. But again, quality of care continues to be at a high level, and we still have opportunity to be better. And I think that we all should take that upon ourselves to help accomplish that. So thank you.
Thank you, Ganesh, for presenting here today and giving us this opportunity. At this time, we'll take questions for sure. As a reminder, go ahead, type those questions in the chat. I do believe you have the ability to unmute yourself as well if you'd like to ask your question verbally as well to Ganesh. And Allie, have any questions come in thus far?
There's no questions in the chat just yet.
Don't be shy.
I'll ask a question. Sneaky again.
Great.
Say, I'm just for my own knowledge or everyone's knowledge online here today. When you talk about stroke severity increasing for stroke presentations,
Yeah.
what was the baseline for the NIH stroke scale pre-pandemic, and then what was shown in the data during the
That's a good
favorable
question,
times?
Nikki. So, the challenge is, that we have thousands of patients, right? So there's a big range. What we looked at was the median stroke severity. So median pre-COVID was 3 among all patients, and the median during COVID was 4. So while just looking at that superficially uh, seems like not a big deal, the range associated with that median number was much narrower pre-COVID and much wider in the COVID era, meaning that patients who were having more severe deficits were more likely to seek medical care, and those who were much milder were like, I don't want to take the risk of having COVID, so I'm going to stay home.
Thanks. So then, just in addition to that, Ganesh, when we think of stroke severity, what was the NIH stroke scale like for those that were treated with alteplase? Did you guys look at that?
So with IV alteplase, it was. Now you're asking me hard questions, Nikki.
Sorry. And you don't have to have the answer here today. It's just
I could say refer to our paper that's published on Friday, but that's not helpful.
okay.
Hold
No,
on.
that's
Hold on,
okay
hold on.
though. That is helpful because that'll help us all to want to dig into it and read more too. And we will be sending that out, everybody, once that link is available. That's why we'll be waiting just a little bit to send out the slide deck and the recording, just to give that document time to be published.
I'm sorry, Nikki. I don't have that information off the top of my head or in what's
No,
in front of me.
no worries. We'll look into it a little bit further too and can follow up. Anyone else have any questions? Go ahead and jump on in here if you like.
There's a question in the chat box. They say, apologies if I missed this information. Where did the data come from? United Hospital, National Database, other? Thank you.
Coverdale. So this is the Coverdale program, which, as Nikki pointed out at the beginning, Minnesota is a part of, and is what CDC funds the Department of Health to partner with every hospital. So this data is comprised, well, the data from this discussion was from 9 states, but overall there are 12 states in which data is submitted and in which we can extract data and learn these trends.
Hi, Ganesh. This is Carol Draghi-Miller from Regions. Do you have the access to the utilization rates for alteplase and thrombectomy that you were able to get through the Coverdale data for pre and what were they exactly? I know they rose and dropped, but
Sure. So alteplase dropped from 55.7% pre-COVID to 50% during COVID. So that was considered significant. And then thrombectomy increased from 34% to 40%.
and that's utilization?
Yep.
So the number of cases over the total number of ischemic cases, those are pretty high rates.
So those, hold on one second.
Because I think of 20% utilization as, you know, pretty
Yeah,
typical.
I'm trying to think of what the denominator is. Hold on one second.
Oh, okay.
So overall, if you look at the denominator of all stroke patients, it went from 17 to 17.7%, so no real difference. So of all patients, 17% got either alteplase or thrombectomy.
Okay.
I don't have, so just like you said, so that's no major difference, but I don't have the actual denominator for how many got thrombectomy only or alteplase.
Okay. All right. Thank you.
I don't see any other questions in the chat as of right now.
So as we wait, I'll just jump in and provide some positive feedback in saying that I think this information shared here today is an obvious direct reflection of the amazing work you guys are doing. To see that there was a minimal change and shift in these performance metrics is just awesome. I like how Ganesh brought up some areas of improvement that were identified pre-pandemic, and it gives us ideas for areas that we should continue to focus on now and moving forward.
All right, any other questions?
No other questions right now. Carol says thank you, Ganesh. And Mimi has put in the link to the survey to get your certificate of learning for this webinar. It'll also be included in the email that you'll get out with the slide deck and everything. Thank you so much, Ganesh.
All right, thank you everyone. Be safe and keep doing what you're doing for our stroke patients.